Today, just talking about some neurocutaneous syndromes. The most common ones that we see, there are definitely more than these that I'm not going to have time to squeeze in today. But the goal is really kind of like visual association, kind of, when we prepare for boards and training, it helps to see just kind of the same thing a lot of different ways and a lot of repetition. And so hopefully just kind of raising awareness for things that we can be on the lookout for so that we help our patients by picking it up early. So, let's see. I'd like to advance my slides. Sorry, one second. Okay, there. No disclosures for me. Objectives for today. Just being aware of the skin findings for three of the most common neurocutaneous syndromes we'll be talking about. Um, some of the ways that these patients can present at different ages to us. Some of the serious complications that we're trying to uh, monitor for and inform patients about. And then after diagnoses are made, how do we help in the surveillance of these patients to help with managing their condition as best possible? And please feel free to ask questions along the way. This is much better when it's interactive. So vignette number one, 7-month-old male with a history of developmental delays and 7-year-old male with history of developmental delays and autism spectrum disorder. And you see these things on his exam. What's the diagnosis and what do we need to do for this patient over the long term? Second patient, 12-year-old girl with persistent progressive headaches for 3 months. And when you take a look at this patient, you notice these things. And what do we need to do for this patient for this headache and also for the long term? Thirdly, 14-month-old female comes in for a well visit, doing well otherwise, but new to your clinic, and then you notice this on the face, on her face, and then what do we need to check for and be vigilant for in this patient who's otherwise doing well? This is another one that I was going to talk about, but I realized we're not going to have time, but I'll just show it. Another one, 7-month-old who had this scary looking rash in the newborn period, and then it became this kind of uh, flowy, marbly, kind of hypopigmented skin finding later on. So neurocutaneous disorders, as the name alludes to, hopefully, can you see my cursor? Conditions affecting the nervous system and skin, and they have their origin in the way that our bodies develop from the neural crest that develops into the central and peripheral nervous systems and the skin and the pigmentary cells. So as you look, as the cells differentiate and becomes ectoderm, the ectoderm develops into the nervous system as well as skin, nails, and hair, again, which are places where we have clues about these problems. And sometimes patients ask me why we're looking at the skin so closely, and that's because often there'll be clues about the nervous system or the cause of problems in the nervous system. And similarly for the eye, the lens and the cornea and the retina also have ectodermal origins, and hence we see some of the manifestations for the neurocutaneous disorders there. And so in general, the three we'll be talking about today are tuberous sclerosis, which is related to TSC1. Most cases are TSC1, TSC2 gene-related, neurofibromatosis, which has problems with the NF1 gene, and Sturge-Weber syndrome, which has problems with the GNAQ gene. They all have association with epilepsy, but most of the patients that we see with epilepsy are either with TSC or Sturge-Weber, but all have the potential to have increased risk for seizures. And in general, If Hawaii has about 15,000 births per year, and we have about 300,000 children total in our state, TSC is about 1 in 6 to 10,000. So maybe each year we get 1 to 2 new patients being born, and about two-thirds of the cases are de novo. So sometimes folks will say like, "Oh, why are we looking for a genetic condition? Because no one in the family has this." Um, it's because a lot of times it's new in the patient. So it doesn't, even though it's genetic, it doesn't have to run in the family, as we know. But I would also say that there's been a number of times where we diagnose the child, and then we look at the parent's face or arms and skin, and then we say, "Did you get yourself checked?" And sometimes, folks are walking around with the same condition, not knowing that they have it themselves because it's such a spectrum. Even though it's passed down through generations, it can manifest differently. So sometimes we diagnose the parent. Sometimes the parent comes in already knowing they have the condition and knowing some about it, but it really varies. So although genetic, may or may not be familial. NF1, about 1 in 3,000. So we see that more often. So that would be about 5 new patients a year. About half the time it's new. And Sturge Weber, relatively rare, maybe one every 1 to 2 years, we'll see a new case. But definitely we're getting new cases every year for these. So starting with tuberous sclerosis. So again, you're going to see a lot of repetition, but I think sometimes that just helps kind of make us be aware of all the things that could be related. While we're talking about neurocutaneous, we know that it's multi-organ system. So besides the skin and the brain, the heart and kidneys and lungs are also concerns for us. So the spectrum of manifestations again differs for different patients. So for us, I feel like we're relatively biased because almost 100% of our patients have epilepsy, but not every patient with tuberous sclerosis has epilepsy. In fact, we've picked up a few patients who've come to see us because they've had a diagnosis made and have no developmental challenges and no seizures. And so picked up because of renal findings often is the reason, or incidental brain findings. So while there's a high incidence of abnormalities in brain scan and high incidence of epilepsy, not everybody has it. And then once they're found, we need to keep close monitoring because often in terms of things that are life-threatening are the kidney complications, often more in the adult years. And we don't see the lung complications, which is more often in women, but often that's the other problem in the adult years. But mainly the kidney complications are the worrisome things. In earlier years, the tumors that they can develop also were a big concern, but fortunately now we have some better medications that also help for that. But as we'll talk about later, the monitoring for tuberous sclerosis is mainly focused on monitoring for these tumors and kidney problems. Talk more about that a little bit. And so there was a guideline that was out in 2019. This is the more recent one in 2021, but pretty similar in terms of diagnostic criteria and surveillance over time. I'll just comment on a few differences a little bit later. And so in general, the things we think about, which we often see, are the hypomyelinatic macules, the hypopigmented areas in the skin, angiofibromas, which we'll show pictures of, the fibromas, Sjogren patches, and retinal hamartomas, are the things that we can find or these are the things we can find on exam. Retinal hamartomas we'll need the ophthalmologist to help with. Then things that we can only see by imaging below. A thing that's changed, well, I'd say a couple of changes from when I started training to later in practice is genetic testing. I feel is done more often than in the past. Partly before it was questionable how much it was needed because once they have the clinical diagnosis, does it really matter that you have to confirm it? And now that with more distinctions between TSC1 and TSC2 clinical presentations, I think that's some of the justification for these cases. And I've also had my first case of a patient who had no skin findings, but just had epilepsy, and then was picked up on genetic testing. So, while the vast majority of our patients we see end up having seizures and skin findings, sometimes it doesn't always present that way. So the genetic testing can be informative, and also getting cheaper. So again, you hear it over and over, the hypopigmented areas, the angiofibromas, which can be pretty subtle. So sometimes, of course, they start off with just one or two or three, and they almost look pimply because they're on kind of like the butterfly distribution of the face where we think of for like in SLE patients. But they can really get prominent and clustered and large and bothersome. So sometimes they'll obstruct the nostril or bother an eye area. And so sometimes it can be kind of bothersome. The subungual fibromas, more often we see those later in older patients, but occasionally they can present in pediatric range. Again, just a constellation of findings. Again, once you see one, you want to be looking for the others to help with nailing down the diagnosis. So here's the lymphangioma in the lungs, angiomyolipomas, kidneys, the subependymal nodules that are calcified here, hypomelanotic areas, angiofibromas, oncofibroma, and then often there can be pressure problems behind the eye. Again, not to make you too tired of this, but just sometimes the repetition helps. And angiofibromas, plaques in the forehead. And so the Woods lamp, so sometimes that's very helpful for patients who are fair-skinned. Sometimes the macules can be very hard to see on fair-skinned folks, and that helps to bring them out. Shagreen patch, pits, and angiomyolipomas, and then the tubers and subependymal nodules. And interestingly, some patients can have a ton of these and be very symptomatic, and some can have a few and be very symptomatic. So it doesn't always necessarily pair that more brain lesions means worse development or worse epilepsy. But we do want to particularly watch when there's nodules that are growing near the foramen, because that's often the ones that become obstructive and cause hydrocephalus if they turn into a giant cell astrocytoma. So again, just realizing that some things tend to present in infancy, but there are a number of patients whose manifestations might show up later. And so often we might not see any findings earlier on, but as kids get older and you keep looking closely, then they might meet criteria later if it hasn't shown up already. So there's definitely an age-dependent relation to clinical presentation. So again, when I first started, often neurosurgery was getting called for the subependymal giant cell astrocytomas because once they started causing hydrocephalus, time was limited in terms of doing interventions. The good thing now is that there's medications, mTOR inhibitors, that are available to both. Initially, they were approved for angiomyolipomas. Then they got approved for the SEGAs, the subependymal giant cell astrocytomas, and now they're approved even for refractory epilepsy, because once you start on them, they kind of help everything. And it's quite remarkable in terms of the amount of patients who now don't have to go to surgery because the medication tends to either stop the growth or even make them reverse. And interestingly, although it's not indicated for the other manifestations, a lot of times their skin will clear up, and some of the other things that are more cosmetic-ish will also improve. So helpful medication if it started it does cause problems with oral ulcers and immunosuppression to a certain degree. And so sometimes it can be challenging to have the kids take it regularly, but um, definitely a good alternative to neurosurgery. And because of this, there in the guidelines that we do recommend getting MRIs uh, on a scheduled basis more often if there's a lesion that's growing quickly. It can also present prenatally, and so sometimes the cardiac tumors that show up will come by, make a prenatal notification to get checked out. And the good thing about them is, in general, if they're not obstructive and causing uh, cardiac compromise early on, then they tend to be stable and regress. So in general, I would say once, if they're doing okay with them, they don't tend to cause problems later, although often the cardiologist will continue following. And then from the kidney standpoint, again, our fear is the developing cancer, renal cancer, and it often starts more in young adulthood, but usually much younger than in the general population. And so for that reason, they're also getting abdominal scans. Before we used to do ultrasound, and now the requirement says MRI, although for some patients we still ultrasound until we see a lesion that's needing to be followed. Sorry, I didn't enlarge this, but with tuberous sclerosis and challenges with learning, there's also a fair amount of autism and uh, intellectual disability that can be quite substantial. So on one hand, I have patients with tuberous sclerosis who he's a bioengineer and in college, and I have patients with tuberous sclerosis who are completely dependent for all their ADLs. And another one who they're trying to look for a care facility because he's unmanageable when he's adult size. So it's really a spectrum of clinical presentations. But in general, of the ones that we're talking about today, there's a tendency for much more intellectual and behavioral challenge. Because, and again, because of the way they present over time in terms of the manifestations, and prenatally, you may have the heart and brain findings, but a lot of these other ones will manifest more toward the later age. Then these surveillance guidelines are available. So sometimes we're kind of in our silos as specialists in terms of I just order brain MRIs and EEGs, but often my hope is someday we can have a tuberous sclerosis specialty clinic where we're well coordinated and have multi-specialty kind of availability for each visit so they can get everything addressed at one time. But otherwise, they're seeing 2, 3, 4 specialists to help with their surveillance. Thoughts or questions before I keep rolling? So NF1. So this guideline is, I think, older, I think 2019. NF1, we see it commonly. Again, a list of criteria. Mainly we're thinking about the cafe au lait macules, and the size depends on whether the patient's in prepuberty or in puberty. Kind of the constellation of things we think of just to put them together with the Lisch nodules, cafe au lait lesions, axillary freckling. Neurofibromas often don't show up until teenage or adult years, so we can't really expect to see that much in childhood. Later complications with the scoliosis. And we'll talk more about the optic gliomas. So again, there are some things that we can see. The neurofibroma is often not until adolescence, but at least the cafe au lait macules and the freckling in the axilla or inguinal area are the main things that we can see. Other than that, looking closely for the Lisch nodules, sometimes that's helpful to look at the iris and shine the light at an angle. And because of the irregularity, sometimes you see the Lisch nodules easier because you'll see the contour of them on the surface. Otherwise, I again ask for ophthalmology colleagues to help with that. Other than seeing some obviously malformed bone, we often don't go hunting for for bony abnormalities. And again, unlike the TSC criteria, one of the major criteria is having a parent because it's autosomal dominant, so 50% inherited. So once you have a parent who knows the diagnosis, then you just need to find one of these criteria. Again, just the constellation of things, and about half are new, so half of them don't have any family history. And we're similarly, when I started, we almost genetically tested 0 people. But now I would say gene testing is more common, and we'll talk a little bit more about that. And although it does have an increased risk of malignancies, interestingly, in contrast to the TSC guidelines that have scheduled every 1 to 3 year MRIs, there is not a recommendation for NF1 to do serial MRI unless they have referable symptoms. So instead of hunting for something that's not symptomatic yet, the general recommendation is you do the imaging when it's indicated, kind of like the general population. But just I would have a lower threshold because we know that these patients have a tumor predisposition. In fact, there's at least a couple, 3 patients I can think of who had kind of, so in general, we often for headaches, we say, don't need imaging, normal exam, imaging adds little. In fact, may find red herring kind of things that aren't very helpful. And there are things that you will definitely see on NF1 on imaging that aren't tumor related. But I would say this is one situation where you'd have a lower threshold just to image in general. We have seen a few patients who have had very big tumors found, but just had they were slow growing. So the presentation was gradual. But with really asking more questions, they might have had some subtle kind of sensory changes, et cetera, over time. So again, just a lower threshold here. And they do have important surveillance things, again, because they can get renal artery stenosis, so very serious high blood pressure, and also ocular complications. Again, just the whole embedded in your brain for the constellation of findings. One thing that's, I'll get to that a bit later. And so the skin fold freckling is a major criteria. And so I would say I don't look in everyone's underarm and groin area necessarily, but if I'm hunting, if I'm concerned about NF1, gotta look in the underarm and groin because that can make or break the diagnosis sometimes. But cafe au laits actually are pretty frequent in the general population. It's very common to have 2 or 3. So I think that's partly why they had an age and number criteria for NF1 to have at least 6 of a certain size. And interestingly, there is, so one would think that if you had diagnostic criteria, if you meet the criteria, then that's the diagnosis. Otherwise, it's not that helpful of a diagnostic criteria. But this is one situation where there is an overlap with this Legius syndrome, a spread 1 gene, different from the NF1 gene, where you actually meet the criteria by the skin findings, but you don't develop the NF1 problem. So that would be helpful to know so you don't, not keep worrying and monitoring for other related problems. And there's a whole host of other kind of conditions that can have cafe au laits and other clinical findings that are not NF1. But in general, they will have fewer and not meet the criteria for the skin findings. So there's still a genetic condition, but not meeting the NF1 except for the Legius. So again, just axillary freckling, it can be pretty subtle. I've heard it said that freckling is a misnomer because it's a not sun-exposed area, so they just call it macular lentiginous, but freckling is easy to remember because you know what you're looking for. It's amazing what you find when you're hunting for axillary freckling. So this must be some deodorant commercial or something. But a lot of these are just Google images, so I haven't cited them all. But here's the Legius syndrome. So for me, I thought, wow, I'm hoping that there wasn't someone that I diagnosed in the earlier years who met the criteria who actually didn't have NF1. And so, in a way, at least it's a it's better to miss something that's more going to be more benign than something that's worse, I suppose. But um, I can't recall the folks I saw in the earlier years when we weren't doing testing regularly. So just as a FYI, sometimes they can make criteria. They can even have big heads. They might have some learning challenges, which are pretty common, but may not necessarily have NF1. And why are we more concerned about NF1 besides having um, neurofibromas, which can be disfiguring? They can also have malignant nerve sheath tumors that you have to keep close watch on. So again, just the consolation, think about the eyes, think about the grind when you see the cafe. So usually we're starting from here and then branching out to these other things. Some of the bony dysplasias, again, you'll have malformation or you'll have to go hunting for it. A lot more scoliosis. Some of these are obvious, it's you're going to do imaging early. But the so interestingly, the optic pathway gliomas actually, we do have a fair number of patients. And the odd thing is that although it's a glioma, it's a tumor on your optic nerve, which just sounds bad all around. That's the best possible way to have an optic glioma because these patients tend to do well. In fact, a lot of them have no eye symptoms at all, despite having this big mass on their optic nerve. And so, interestingly, optic glioma with NF1 is kind of a better scenario than having optic glioma without NF1, because that will threaten your vision much more. But often we're doing serial imaging and following up with ophthalmology. So neurofibromas, again, often they appear later and they can be much more subtle than this. Often they're just flesh colored if they're a little bit deeper. A lot of times when you hunt it up, you'll get these are, I would say, still very mild. They'll often show the worst case scenarios of patients with a lot of huge ones. And you may see some folks in the community who have, unfortunately, are working with this, dealing with this situation. In general, though, we don't tend to do something for them unless they're compressing a nerve or causing discomfort. So often, even though patients have 1, 2, 12, 20, until they're causing like a neuropathy, we won't go after them because they often tend to just grow back. And before I had a whole sort of things that look lumpy, but not everything that's a lump is a neurofibroma. And the other one that's interesting also is plexiform neurofibroma. So sometimes they can be pretty subtle. This is not subtle, but it almost feels like a thick, a little bit smaller than peas, kind of like gravelly feeling under a patch of thickened skin when it starts off. But again, we're still concerned about malignant transformation. There is a new medication that's out for surgically inoperable plexiform neurofibromas, but this one, raises us a little bit more concern in terms of close monitoring. So sometimes I have patients with it on their ears, on their ankle, just kind of all over, and a lot of them miraculously just kind of aren't very much bothered by it, even though it's seems pretty bulky. Nerve sheath neurofibromas, again, they can be anywhere, and we'll get to a little bit more about those later on. Again, the Lisch nodules for the diagnostic criteria, but there can also be retinal hamartomas, again, where sometimes they can affect vision, and so again, we want the regular follow-up with eye doctors. So interestingly, again, routine scanning not indicated, partly because there's also these, what they used to call UBOs, or unidentified bright objects, which is just, they will normally have abnormal scans, but they don't have a clinical significance when you find these UBOs. So let me see if I can. So again, early on, it's hard to make a diagnosis in infancy, but most of them will declare themselves by early childhood or mid-childhood. But those who have family history can usually be diagnosed early because you just need to meet one criteria. And until we exclude the diagnosis, we should kind of keep monitoring as if they did have it. Because again, we can pick up other things that will be important to monitor for the long term or treat early. So for their surveillance, mainly from the general side, we're looking for either problems with stature, abnormal blood pressures, again, because you can get renal artery stenosis, scoliosis exams important, looking for retinal hematomas, and precocious puberty are things that we can intervene for. Catching and better to intervene early. Again, the imaging only indicated for suspicion of intracranial problems. Here's the optic nerve glioma we had talked about. Again, usually with a fairly benign course compared to others. Gonna jump here. So UBOs, so often there are bright spots. This is a really bad scan from long ago, but often there's bright spots in the basal ganglia and thalamus that are not normal, but typical for NF1. And so again, if imaging is obtained, we should be reassuring for these patients. So I would say that patients with NF1 have a lower frequency of cognitive and behavior problems compared to the patients with TSC, but they do have just increased compared to the general population, especially ADHD. And so often those are the most bothersome things that we're seeing them for, because epilepsy is much less common. And again, because they can have growths anywhere, it can even present as a GI case in terms of obstruction or malabsorption problems. And lastly, Sturge-Weber. So something that, not everyone may see a case for, but something we learn about from med school, again, for the constellation of findings. Three things: the eyes, the birthmark, and then the brain. So we know that the condition causes venous capillary kind of angiomas along the brain surface, which causes problems with the brain development in that area. Usually not overt bleeding, but with that, also they have bad problems with glaucoma that can develop over time. And over the years, there's so as opposed to the others, which are autosomal dominant and 50% pass on rate, this is not it just tends to be sporadic just to a somatic mutation. They do have a much higher incidence of seizures and focal deficits, because often it's kind of like a stroke-like presentation on this side of with the part of the brain that's injured. And so again, often it's the concerning areas in the V1, V2 distribution. So we think about the branches of trigeminal, and so kind of V1, V2 distribution. And again, in this case, with the malformations, we see the atrophy localized in the area, the abnormal blood vessels. And so this is actually from a dermatologist who provided this more recent guideline. And so they have areas of the distribution. So especially if it's bilateral and involving the eyelid, tends to be areas of more concern. So these are the higher risk areas. Because it's not uncommon to have kids with port wine stained birthmarks who don't have Sturge-Weber. So in general, though, we tend to get referrals for these patients, and they should be followed both for the brain and eyes. And again, not when I was starting training, but in the years, they've identified this GNAC mutation, which is related to the manifestations that we see. And so with that abnormality, it contributes to capillary malformations, and those malformations contribute to the brain abnormalities that cause stroke-like symptoms. So patients can have hemiparesis or other focal deficits, and with that a high incidence of epilepsy, and glaucoma, which often can be so severe that they often lose vision in the affected eye, the ipsilateral eye. For the port wine stains, which sometimes can get very thick and deeply colored and a little bit disfiguring, they can use pulse dye laser therapy, which has pretty amazing effects in terms from the cosmetic standpoint. For the ongoing stroke-like changes, we often keep patients on aspirin. We don't have better therapies, unfortunately, at the present time, and we're using anti-seizure medicines as needed for their epilepsy. The glaucoma is treated by the ophthalmologist. I can't really comment there, but hopefully in the future, with a lot of genetic conditions that we used to say had no cure, hopefully we'll get more things developed. I'm going to skip this, which is just about imaging in Sturge Weber. So again, looking at all three, for a TSC, the subcortical tubers, these white regions, sometimes they have radial lines of abnormal development, and then the subependymal nodules, and sometimes giant cell astrocytoma, often near the foramen. And these patients get every 1 to 3 MRIs, 1 to 3 year MRIs. NF1, the UBOs, the unidentified bright lesions, pretty common, not clinically consequential, but they can develop tumors that do need close monitoring and possibly surgery. But they're imaging just by clinical indication, not by routine surveillance. And then Sturge Weber, similarly, you can see the enhancement of the abnormal vessels and sometimes some underlying atrophy. But again, often more indicated when they're actually showing signs. So back to this one. What's the diagnosis?
Go ahead and put it in the chat, folks.
Well, I don't know how to see the chat.
I will tell you when something starts to come into the chat.
Yay.
Okay, so if anyone who can't see the chat, if you happen to be driving and listening or something like that, Naomi Marita said it's tuberous sclerosis, and Renata got it right too.
And so I guess for those who aren't having the video, we got angiofibromas, periungual hypomelanotic macules, and adenoma sebaceum, or Sjogren patch. And for the long term, we talked about eyes, kidney, and brain monitoring, as well as learning and development behavior. And for the next one, patient with cafe macules and axillary freckling and a solitary neurofibroma. You know the diagnosis. What are 3 things we need to monitor over the surveillance for this patient?
Go ahead and drop your answers in the chat, folks.
Or any questions too. Yay. Yeah, so definitely we'll need serial eye ophthalmology follow-up. Brain not so much in the imaging standpoint, but close high suspicion for learning disability, ADHD. If there's persistent macrocephaly, focal deficits, progressive headache, then we might, image because they do have a higher risk for brain tumors, but these patients don't have routine imaging recommended by their guideline. The other one would be growth, uh, precocious puberty, and blood pressure. So even though again, blood pressure just something that kind of can sneak by until it gets really severe, they can get renal artery stenosis. So just something to monitor. And lastly, for the patient with the V1, V2-ish port wine stain, yay. And what's the triad of complications they can have? Thank you, Naomi. Thank you, Renata. Yep. So most commonly, we're seeing them for hemiparesis, epilepsy. They can also get really bad glaucoma. So things we need to track closely for them. Thanks, everybody. The question is characteristic skin findings for TSC. I feel like the thing that we remember the most is the hypomelanotic macules, but these are just some other skin ones. Again, ectoderm, nails, hair, skin. And so besides the skin, you can have things around the nails. And then the facial angiofibromas, I would say, are the second most common thing I see. The little bumps that look like pimples, but they show up too early. They show up like, at 5 and 7, 8-year-olds before you're actually going through puberty. So um, kind of like little papules that, again, you might just have half a dozen at first before they really increase in later adolescence. And then the Sjogren patches, those you really have to kind of look close. It's almost, again, with the light at an angle to see the irregularity on the skin, more subtle, but all of them are major criteria. So especially if someone doesn't have a lot of white spots or hard to see the white spots, important to pick these up. Again, because not everyone I'm learning presents with seizures or delays. It's a poorly worded question. All of them are possible presentations. I would say seizures are the most common presentation, but really for TSC um, and Sturge-Weber. So I guess the thought was just to be aware that any or all of them could be presenting symptoms. So seizures, vision, eye problems, or delays and learning challenges. So again, if someone comes in with delays and learning challenges, gotta check the skin. Gotta check the skin. Identify some possible serious complications of neurocutaneous syndromes, and so stroke. Oh yeah, I didn't talk about these. So stroke, NF1 actually is one of the conditions that can predispose to moya moya. So NF1, Down syndrome, sickle cell disease can cause moya moya syndrome. So not moya moya disease, but they can have a moya moya disease that leads to pediatric stroke as one of their presentations. Sturge-Weber just by nature has because of the blood vessel malformations on the brain, although it's kind of a gradual progressive presentation. TSC uncommon, less than 5 to 10%, but there is some increased risk. The other case that had the strange pigmentation in the beginning, incontinential pigmentia, also has high incidence of stroke. I didn't go into that one. Tumors, NF1 and TSC, renal failure, TSC and NF1. And yeah, all of the above for TSC, brain, kidney, and eye exams.
Great. Thank you. So let's see if we have a couple of questions. One was if you could talk about your bonus case pictures. And the other was from Naomi Morita, which discipline should be the primary MD following or monitoring a now senior person who is neurologically and intellectually asymptomatic, but has had multiple cutaneous manifestations with a negative brain MRI, renal ultrasound. I think that's what that stands for, an echocardiogram many years ago.
Okay.
So do you have any recommendations for like who should be primary at that point?
So I think it depends on when we say multiple cutaneous manifestations, what they are. So if we're talking about someone who has TSC-like manifestations, so there's TSC manifestations and there's meeting criteria. Similarly, like NF1 manifestations or meeting criteria. So I mean, I think if someone had like two or three cafe au lait or two or three well not three, but like a couple hypopigmented macules, but they don't meet the skin criteria, then I'm not sure how much further down to go. Uh, I'm assuming though that if they got the brain scan and renal and echo, then they probably had TSC-like manifestations. And if they met the TSC criteria, then this might still be someone who's worth getting the genetic testing for. Because if they did, well, number one, if they met criteria, they should still be going through the surveillance. Uh, if they met criteria, but there's still some question, then maybe the genetics will help to compel to keep doing the lung scans and the brain scans and the renal scans into later adulthood. Oh,
Looks like there's a
yeah.
clarification that
Yeah. So
the
I mean,
patient. Oh, you can see it. Okay.
yeah. So I think if there's one patch, but if there's one hypopigmented macule, but they meet it by the fibromas, angiomas, and patch, then I'd say that's probably clinically diagnosed as TSC. Probably they could get the genetic testing and they should still proceed with the monitoring. So I think the hard thing for so for some again it's different because often we get referred to cases they already have neurologic symptoms, so we're kind of like marching them through the surveillance. But I think this might be one situation whereas if it's their PCP, they might still do the surveillance until they start finding things um, and then refer. So there's been different situations where the specialist doesn't want to see them until they actually have an abnormality in the organ system versus just helping with the surveillance, even though they don't have an abnormality in the organ system. So I think it might depend on the specialist preference, but ultimately I think it would be helpful if the PCP kind of kept going with it.
I want to make a quick plug too for referring to genetics when doing genetic testing because I had a discussion recently with Dr. Bala about the importance of the genetic counselors and really making sure that parents and if old enough children understand the potential consequences of the testing that they're undergoing, and then there are certain times where you can like opt in or out to certain like additional details that may come up in the genetic testing that you're sending, especially if it might be a panel in this case, but if you were doing like a exome or something like that, it often comes up. So he was really encouraging me for our inpatients, but I would say the same for outpatients to have them see the genetic counselors and to get that genetic testing through the genetics services as opposed to even if we know what to test. But I think I at least don't feel like I have the expertise to do appropriate counseling, before that. So that was a really good learning point for me, and I just wanted to make a big quick plug for that too.
Thank you.
Yeah. And then the other question, Keith, was if you would
Okay.
be able to share your bonus case. And we have like 2 more minutes. I don't know how long the bonus case was.
Yeah, so incontinentia pigmenti is an X-linked dominant condition that I don't have other slides for it right now, but um, so it's often lethal in males, but females survive with it, and they often have kind of severe intellectual disabilities, kind of small peg teeth, small kind of hypoplastic nails, pretty severe delays in development, and often challenging epilepsy. But one case that we just admitted or got admitted recently, I think presented with her first seizures, and then on the scan was found to have strokes. So they also have increased predisposition towards stroke because of abnormalities in their vessels. So seen much seen much less frequently in our population, but definitely is out there. And I don't know if you remember the lines of Blatchko, but if you Google that, there's certain ways our skin develops. And so when you kind of stand back and look at these patients, which seem to have kind of like these chaotic marbled hypopigmentation, you'll find that they follow these developmental lines kind of in a swirling but kind of symmetric expected pattern. And that's helpful to see and helpful to say, hey, um, I think we need to check further here because again, that one also eyes, hair. Well, eyes need to be may need some checking too. What and where
Yeah.
does genetic testing? Ooh, yeah, that's a good question about the genetic testing. Uh, what and where to send genetic testing that will not result in the recent outcome of selling data? Not sure about that.
Yeah, I'm not too sure either. I think, there's definitely a difference between commercial, like 23andMe, like, where did your ancestors come from kind of genetic testing that then will also potentially screen for BRCA genes and other common disease-causing genes. And certainly there's definitely concern there. I think equally that there is certainly concern with our kind of lab-based genetic testing, which often goes to certain companies, that the hospital has contracts with that we don't necessarily know what that could mean down the line, especially if the ACA is ever repealed. So that is certainly something to think about. Like, are there consequences to finding out things that might affect your health down the line, or might affect your descendants' health, but not yours, and things like that. So I think I don't have a quick answer for that one, Renata, but my sense is that is important. Sort of another reason why it's important to have the genetic counselors, do what they are best at and have families make an informed decision rather than just kind of agreeing to letting us send stuff without necessarily understanding the negative consequences that could happen.
Yeah, I think one small tidbit from our side is the 10, 20 years ago, for example, there were these twins who definitely had something genetic and who were hospitalized for a very long time. And we ended up, I think, had to ask the hospital to approve their $20,000 testing that did end up after they had, thousands and thousands, thousands, thousands of dollars of other testing, kind of figured out what they had. Now it's much cheaper and much easier with just swabs. And so the companies actually for epilepsy offer free testing if their seizures start below a certain age. I think partly because they're trying to build their database, but now that barrier to getting testing is much lower, but hence probably why Dr. Bala has, the concerns about, making sure we're responsible with consulting. But I would say that it also has unlocked a ton of cases, including like those
Yeah.
where the TSC, diagnosing TSC without skin findings, like we have never found that patient. So it,
Yeah. Yeah.
pros and cons, yeah.
Yeah, maybe that's a good thought for us here at Peds Echo to invite the genetic counselors to come and talk about that. I think that would actually be a good topic. Yeah. Well, thank you, Keith. We are out of time. In fact, we're a couple of minutes over. So thank you for everybody who stuck around. As always, we learned a lot. We really appreciate it. And we look forward to inviting you back, in a few months or a year. So thank you. Thank you. And lots
That's
of
fine.
great thank yous in the chat as well. We appreciate you.
Thanks.